Welcome back to Understanding Human Anatomy and our discussion of the mechanism of respiration. This is part 2. You see on the slide I have a diagram of the body wall, the diaphragm, the parietal pleura, the visceral pleura, and the 2 lungs. Let's assume that our drawing here we're at the beginning of a quiet inspiration. Now, by quiet inspiration, I'm talking about probably how you're breathing right now as you're watching this video. You're just sitting still, you're taking normal resting breaths in and out. Now, at the beginning of quiet inspiration, the diaphragm contracts. Now, as I said, the diaphragm is a domed-shaped muscle. So when the diaphragm contracts, it flattens out. So the diaphragm will look more like this. And what we have done is increase the dimension of the thoracic cavity in the superior-inferior direction. We've made the thoracic cavity slightly larger. As this happens, the external intercostal also contracts. Now, when the external intercostal contracts, it pulls the rib that's on the bottom, the inferior rib, up towards the superior rib, and it causes a rocking motion. And it's often described as a bucket handle motion. So if we looked at a bucket handle like so, when the intercostal muscle contracts, it pulls the handle up like so. If we look at a rib, it'll be roughly this shape. When the intercostal muscle pulls, it pulls the rib up and out. So it pulls it into this position. And that increases the lateral dimension. So if we look at our diagram, the body wall will look like this. It will increase in size in the lateral dimension. And again, I've pretty exaggerated the amount of change in this diagram. So now if we take a look at the pleural cavity and lungs after this happened, we'll see in the next slide how they appear. So you see the lungs get larger. The volume of the lungs increase. With the volume of the lung increasing, you can see that lung volume increases. And as lung volume increases, intrapulmonary pressure decreases, and thus air flows into the lung to equalize the pressure, to bring the pressure back to atmospheric. And in so doing, you have taken a breath in. You have inhaled. Now, to exhale, a quiet exhalation will find the diaphragm relaxes. And when that happens, the diaphragm moves superiorly. It moves into the thorax, bulging into the thorax as we had at the beginning. The internal intercostal muscles contract, which pulls the rib down to the position it was in at the beginning of the inspiration. So the lateral dimensions of the thorax get smaller, the superior-inferior dimensions of the thorax get smaller, and we return to our original starting point. As we see here, back to the beginning. When this happens, lung volume decreases, which means that intrapulmonary pressure increases, and that makes the pressure inside the lungs greater than outside the lungs, greater than atmospheric, and air then will rush out of the lungs to equalize that pressure, and you have exhaled. So a quiet inspiration and a quiet expiration. Now, I'm not going to do diagrams for forced inspiration and expiration. Forced inspiration and expiration would be taking as deep a breath as you can and then forcing all of it out. This moves a much greater quantity of air in and out of the lungs. But to just explain what happens in a forced inspiration, we again have the diaphragm contract. Now, it may contract much more strongly, so it gets even flatter to increase the superior inferior dimensions even more. We still have intercostal muscles, the external intercostal, increasing the lateral dimensions of the thorax. But we'll also have some accessory muscles. We'll have sternocleidomastoid, sternomastoid contracting, and we'll have the scalene muscles. There's an anterior, middle, and posterior scalene. The scalenes pull on the first rib and second rib. Sternomastoid pulls on the manubrium. And together they pull the sternum up. And when they pull the top of the sternum superiorly, the inferior end of the sternum, the xiphoid, moves anteriorly. And so this increases the anterior-posterior dimensions. The anterior-posterior dimensions to expand the chest even more. We'll also use serratus anterior. Serratus anterior takes origin from ribs. And if we hold the scapula in place, serratus anterior will pull ribs up and out. To further increase the lateral dimensions of the thorax. Now, for a forced expiration, we again have the diaphragm relax. We have the internal intercostals. They will contract to pull the ribs down to reduce the lateral dimensions of the thorax. All the accessory muscles will relax. But then we will contract the abdominal muscles. And when the abdominal muscles contract, they increase pressure in the abdominal cavity, and that increased pressure in the abdominal cavity forces the diaphragm further superiorly, forces it further into the thoracic cavity. It bulges more into the thoracic cavity, which decreases the superior inferior dimension of the thorax even more, and forces more air out of the lungs. So forced inspiration and expiration, we're doing the same thing as we do during a quiet inspiration and expiration, plus adding additional muscles to help move the thorax even more. In the next slide, I'd like to explore what happens when the intrapleural pressure equalizes with atmospheric pressure. Now, we said earlier that intrapleural pressure is less than atmospheric pressure. And that pressure differential is necessary to keep the lungs pulled up against the body wall. Works a little like a suction cup. Now, there are situations where that relationship is lost. In other words, the intrapleural pressure becomes equal to atmospheric pressure. One way for that to happen is for a wound to occur in the chest wall. This could be caused by a weapon or just falling on something sharp that pierces the chest wall, so that there is a direct connection between the pleura and the atmospheric pressure. Another way for this to happen, which I'll draw in on the other lung, is for the wall of the lung to rupture. Since the intrapulmonary pressure is atmospheric, if this happens, then again the pleura and the atmospheric pressure will equalize. When this happens, it's called a pneumothorax. And when a pneumothorax occurs, the lung will collapse and deflate. So you're not moving air into and out of the lung on that side. I mentioned it could be a result of a weapon, gunshot, a knifing. When you get the wall of the lung breaking down, that's often secondary to an infection. It's fairly common in tuberculosis that the infection builds up and causes the wall to break down and equalize pressure. You also theoretically could have a rib fracture and have a bone splinter pierce the lung wall and cause a pneumothorax. A pneumothorax is life-threatening. If you can't get the lung reinflated, the person may not survive. When surgery is done on the chest, and by definition, when you do surgery on the chest, you're going to cause a pneumothorax. You have to cut through the chest wall. Surgeons will put a drain into the pleural cavity, put it down here in the costodiaphragmatic recess, run the drain out through the hole, sew up around the hole so that the tissue is tight around this tube, and run the tube into a trap so that as movements start to happen in the lung, you force air out and it goes down into this trap and can't get back, and thus reestablish the net negative pressure of the intrapleural cavity. After that's reestablished, the tube is then. A significant complication with the pneumothorax is called a tension pneumothorax. In a tension pneumothorax, the opening between the atmospheric pressure and the intrapleural pressure has a partial closure to it. Tissue acts as a one-way valve so that air gets sucked in but then can't get pushed back out. So in a regular pneumothorax, you get collapse of one lung. In a tension pneumothorax, pressure keeps building up because more and more air gets into the chest and pushes the side of the pneumothorax, pushes over to the other side, inhibiting the other lung from inflating. And the net result can be life-threatening. Pneumothoraxes are treated by restoring the intrapleural pressure. That concludes our discussion of the mechanism of respiration. Thank you for your attention.